thank you so much for coming on and talking with me. As we were just talking about before we started recording, I am super excited to have you come chat with me because I'm doing this little series about just different pathology careers. And you and I both know each other quite well. We studied together for boards, and that's how we met, right? I mean, we didn't know each other before that. I guess we
Yeah, I think
started
yeah.
that study group, which you get to know people really well when you're doing something so intense. So, I've been pals for a while, and I appreciate you coming on and just kind of telling everybody about like your career and how you got into pathology and just anything you think that people would like to know. And for everybody watching, I am doing this from my car, so don't be distracted by my background. My internet's terrible. So we're just going with it. But yeah, so I guess one of the things that I've been asking everybody is just sort of like, so Danny's a veterinary clinical pathologist. I did an interview with an anatomic pathologist and a vet tech specialist in clin path. So you are my first clinical pathologist, fellow clin path. And so one thing that I'm just sort of asking people, because I think one of the things that people are really interested in is like, well, just from the beginning, like where did you start getting the idea of going into path? Was it a long time ago? Was it in vet school? When did you decide to do it?
Yeah, so I guess I should say, so I did my training, so vet school, I went to University of Wisconsin, and then I went off and did a small animal rotating internship at a private specialty group in Seattle. The intent was to apply for internal medicine residency, but then about right before the match, I realized that I was doing this because other people expected me to do it and not because I wanted to do it. So I kind of had that realization that, any of these residencies they can be soul sucking at times, although ClinPath is definitely not the worst residency out there compared to some of the others. And so you just need to really make sure that this is what you want to do. And that you can sit on your butt or stand at a microscope all day and not get dizzy and not get sick and not get headaches and just kind of deal with that strain. Because of that, finished my internship, went out into private practice. I'm from the Chicago suburbs, so I moved back to Chicago, and then I was in private small animal practice for 2 years.
So that was after your internship?
After internship.
Yeah.
So that was primarily, cats and dogs, saw like the rare bird, or ferret, but mostly cats and dogs. And then kind of what happened is after I went to general practice thinking like I was going to find myself, right? Like, okay, maybe I will love general practice and this is what I want to do forever, or like maybe I want to specialize, who knows? And I kind of realized a year into practice that although I really did enjoy practice, it was fun, I liked my clients, it was interesting, I kind of was losing interest after the diagnostic phase of things, and I just got kind of bored with chronic disease management. And then I also kind of realized I did not have the intent of knowing that I wanted to be a pathologist in vet school or before vet school. I knew I liked working at the microscope. I was a vet assistant growing up at a hospital and worked in the lab a lot and looked at a lot of fecals and urine. So I liked that stuff, and I really enjoy clinical chemistry kind of evaluation, but I didn't understand that you could be a veterinarian and not touch animals, right? Like on a daily basis. I didn't understand that. But then after about a year of practice, I was like, I really like kind of the teaching client aspect of this. And I really enjoy like looking at my samples under the microscope, figuring out what's going on. I am a very impatient person by nature. So like, I just need to know. I need to know what's going on. And, I was like, what, this is interesting to me. And I did well in, not that you have to have done amazing in path in school, but I did well in path in school and I liked it. So I reached back out to my mentors at Wisconsin and just said like, hey, I'm kind of considering pathology, not sure. And they invited me to spend like a week there. So I went and spent time with them and they're like, you kind of need to see what it's like, the reality of being a pathologist day to day. Like I said, sitting down a lot, can you deal with not touching animals or interacting with clients? Like if that's what you're passionate about. So I went there and spent time with them and realized that I did really like it. And so then I decided, I'm going to give it a shot. I'm going to apply for residency and see what happens. I think the other thing, for those of you that are considering residency, the other thing I got out of visiting was I saw the real side of ClinPath that you don't always see. So we always think of like cytology, right? And hematology and pretty pictures and pretty cells, but a lot of training is like quality assurance and quality control and laboratory management. And I do not like statistics, and I am a lab director, looking at statistics. So there is that side of it that is part of our training that I didn't even know about was a thing until I visited Wisconsin. So then, yeah, I'm really good at making long stories longer. So
no,
then
that's what this is for.
So I visited Wisconsin, realized that's what I wanted to do. I applied to a bunch of programs, and luckily, was accepted. So I was accepted at University of Minnesota. So that's where I did my residency. And then when I was done, the intent was I was kind of in talks with a private specialty group to go back to Chicago and kind of get their own kind of internal ClinPath service up and running, but that fell through. So then I was in talks with another kind of private diagnostic group doing kind of just like what you used to do for Antech, right? So just, diagnostic cytopathology. But there happened to kind of a surprise position opened up at the University of Minnesota right before I was in talks with these other diagnostic labs. And it was a clinical instructor position, so kind of teaching and clinical service. And so I was like, you know what, let's see if I like academia. I like teaching. Let's see if I like this. And so I took that position, and then it ended up turning into I guess I call it now like a real position because they made it a continued position. So I'm now an assistant professor, mostly clinical track. So 70% of my job is clinical service. Part of that is I am the lab director for the ClinPath lab here. So we can talk about kind of that avenue later. And then I also do a fair amount of teaching. So about 25% of my time is teaching. And then the rest of my time is spent with like collaborative research and outreach. But yeah, I feel like with your question, the path decision was definitely not predetermined and was simply just based on my interests. So I think that's for those of you that are returning back, who are thinking about residency or thinking about ClinPath specialty, if you're a technician, I can say as someone who is on a residency selection committee, we are not looking for someone who has tons of experience in ClinPath. I mean, the reality is like, you don't know anything about ClinPath. You learn the tip of the iceberg in veterinary school. And so we do not have expectations that our incoming residents know a lot specifically about clinical pathology. We have expectations that they're passionate about it, they're interested, and they want to take the time to learn. Certainly now there's ClinPath internships, right? So you can get some of that applied experience, but that is not a requirement. And we just want people that are passionate.
I think that's so good to say, because I remember when I went into my residency, and you just never really know. I mean, I'd already been accepted, and it was like my first, I don't know, day, week, whatever it was. It was very early. And I just didn't really know exactly what was expected of me. And I didn't, of course, none of us really want to embarrass ourselves. I mean, I had interest, but I just done an internship. And so I wasn't like studying ClinPath. And I remember when my mentor said, because she could sense that I was like, not sure what I was supposed to know. And she said just what you just said, like, you're going to learn everything you need to know here. So you can just relax and stop trying to like worry that you're not going to get something right, because you're not, because it's like your first week. So it's okay. That's not what you're necessarily looking for.
I tell my residents still to this day, I'm like, I still remember the first case I wrote up by myself, and I wrote it up wrong. Like, I wrote up a pigmented basal cell tumor as a melanoma, and I was super excited because I thought I had gotten it right. And then the pathologist looked at it, and he's like, he was very nice about it, but it was clearly the wrong diagnosis.
Okay, so my favorite one of those was I was doing board write-ups, and I don't even have the excuse that it was early on. I think it was late enough that I probably should know, but we did practice board write-ups, and I had a blood smear from a turtle, and I had never seen thrombocytes before. I didn't know that they were nucleated, and so I wrote it up as metastatic circulating carcinoma. I mean, it was like complete, I had no idea. I had to write something. So I'm like, what are those? They're clumping together. Maybe they're epithelial cells. I don't know. that was a good laugh for everybody. But yeah, it's just like, you have to practice, you have to learn, you have to train. That's the point of all of this. So yeah, I love that you say that, because people, I think, really get intimidated with like, I don't know anything about ClinPath. I mean, I'm interested, but they don't want to accept me. But that's not the point. The point is to find, just like you said,
Yeah.
somebody that, all those. So on that same note, we're kind of jumping around, which is totally fine. But I didn't realize you were on residency selection committee, so that's pretty cool. And also note, how are we so old? Like, I feel like we were just studying for boards like 5 minutes ago.
I mean, right, it's only been 6 years, right, or whatever. I don't even remember it.
I know, I guess it has.
5 years.
I guess it's not that long, but
Yeah.
still. But what else would you guys be like? Could you share like what else things you guys look for? That's something I get asked all the time, as I'm sure you do. What kinds of things, if you had a resident, would you want to see on there, just in general or more specific?
Yeah, definitely. So yeah, I will say, like, what's nice about our service, right, is because so there's four pathologists here at the clinical pathologists on service at the U here, who have varying degrees of clinical appointment and resident interaction, but we all kind of work together when we're deciding who we want to take as our candidate, and it's definitely like a group vote type process. But things that I can say we look for, and I think it depends on where you are in your career. I think that definitely plays a role in kind of expectations. I mean, it's just the reality, right? So our current 3rd year resident, for instance, is wonderful, and she was out in general practice for 11 years before she decided that she wanted to go back and do ClinPath. I think what happens if that's your time frame, if you've been out for a while, is a lot of programs will have the discussion is that we don't want someone applying just because they're burnt out from general practice. I recognize that burnout happens, like I totally get it. And it's not like I loved every aspect of general practice, because that would be a lie. There were things that I hated and there were things that I enjoyed. And it's the same thing with being a pathologist. Like, there's things that I hate that I have to do on a daily basis, and there are things that I like. But realize that if you're interested in this just because like you're like, oh, I'm burned out and I don't want to deal with clients, my forewarning would be that you're just trading one bag of problems for another bag of problems. So you're trading an active lifestyle job to a very sedentary job. It is stressful being the life and death decision maker for a patient sometimes. Like, I sit there saying, well, if I diagnose this and the clinician has told me if I call this cancer, the owners are done. Like, that's stressful in its own way, being that ultimate decision maker. So you do trade kind of one bag of problems for another. And I don't mean for this to sound negative, but I think none of us want that. Even if you feel like you're burnt out, don't tell someone, don't, play the positives. Don't like, we don't know if that's the case or not, but definitely play the positives.
And in the same breath, it's okay to say, I remember saying just what you said in my interview about when you said, I kind of I actually used the words lost interest after the diagnostic phase of things, because even though it was, I was kind of being cheeky, it was true. Like, as soon as I was, had the diagnosis, like, I wanted to wish the animal well. It's not that I didn't care what happened to them, but I didn't really want to be the one to manage that or treat that. And I think that's a very honest yet positive and very, I'm not saying use that, don't say things that you don't feel, but like, it's okay to say things like that and to explain, like, and just sit in reflection of like, why do I want to do this? But just like you said, if it's like, I really don't want to deal with clients anymore, maybe find, that may be true, but maybe find a different way to explain that in a little more of a, and this is why I'm choosing this as my route, because you have multiple different routes to choose.
Exactly.
Yeah.
And my clients are now veterinarians, right? So I've just traded a different client subset, and there's a whole different set of expectations when you're dealing with veterinarians than when you're dealing with the general public. So again, like, there's going to be positives and negatives wherever you go. But yeah, so that's something we look for. I know for our current resident, for instance, and she got a lot of feedback, and I don't necessarily disagree with this, but her first year she applied, she didn't match anywhere. And she said, a lot of the feedback I got was, you've been out for a very long time. We just want to make sure that you're really interested in this, and this is what you want to do. And so she ended up doing one of the ClinPath internships. There's a few out there. And that really showed her commitment. And because of that, she didn't apply to us her first year. So we didn't know her, until she applied the second year. But she essentially entered our program like functioning as a second-year resident. Like, she learned a ton in that internship. So I think if you've been out for a while, we definitely look for people to have committed to an interest. So whether you've been sitting, with a diagnostic lab pathologist, a few times a month for a period of time, or you've visited programs, or if you're a member of ASVCP, or been to some conferences, those are some of the kind of things that we look for like a true commitment to the profession. We also really, I can say this because I'm on clinics, 70%. So it's really a lot of the day, it's me and the resident, right? And it's the two of us interacting. So if you can visit or set up like a Zoom call or something like that, I really personally find that personality match to be very important, because we are working so closely together for the entire day. And I would hate it if my resident and I were just butting heads or just so different. I don't think that's going to go well for anybody in the training program. So I think visiting and making sure that you feel comfortable in your program. Like, I still remember visiting Minnesota, and I'm sure Leslie Sharkey will never see this, but if she does, so Leslie Sharkey is like a who's who pathologist in our field, and she was at Minnesota for a very long time, and she was one of my mentors. And I remember she swore about something during, like, we were out to lunch on my interview, and she swore about something, and I was like, okay, I think I can be here. Yeah, like, I think we can make this work,
Yeah.
But I really got a lot out of visiting programs, and I'm sure you had that experience, right? Like, you want to feel comfortable with.
Yeah, and also and not even just, absolutely, that's usually the one thing that I say to people is most important. I mean, maybe not most important, but I feel like it's such an important piece, is the personality match. And even too, like, talking to current residents and seeing kind of how the flow of the program is, because some people personally really, and kind of sitting with your own, it's kind of evaluating how you learn best and what kind of learning you really jive with. Because for me, I kind of like a structured, but also a little more, I don't necessarily need somebody looking over my shoulder. And I don't really love a lot of like structure, but I don't want to just be thrown to the wind. So the program that I want to be in fits that, whereas some people might say, I really am not, like, I've gotten real with myself. I need a lot of like, deadlines. I need, just knowing what you need and just kind of seeing what that program does. Because from talking to different friends that have gone through different programs, there's no good or bad program. They're all great. It's just sometimes, it's the people that are leading the program might be more like, you are free to study, a lot of hours during the day kind of on your own, and you need to be able to do that, without that oversight, versus others that might be more rigid, like, you're logging hours or whatever that you're doing to kind of prove that you're doing those things. I don't even know if that necessarily exists, but just for sake of example. So yeah, just knowing, like, being able to talk to the program and say, like, how are your days structured? Like, and does that work for you as an individual? So I think that's really hugely important. So, and a lot of times, or a lot of, I'm getting a lot of people asking, like, well, what do I do because COVID, I can't visit. And so you guys are doing some Zoom like meetings, and not formal interviews necessarily, but just meeting people. Is that?
Well, we did.
I'm not trying to open the doors for everybody.
Yeah, no. So we did Zoom interviews for formal candidates, and then we have had people who've asked to visit. And so, like, for instance, the resident that we took this coming year, she she's an intern elsewhere, and had a free block. So she's like, hey, like, I'm interested in your program. Could I? So we normally would do like in person if we have the time, but with COVID we couldn't. So she visited remotely over Zoom, and we were able to get our camera, to show her what we were seeing over Zoom. It was a little awkward, it's a little slow and kind of janky, but it worked. So I don't want this to sound like we take, hundreds of visitors, a year, but people who are showing like definite interest in our program, if we have time, we will have visitors and things like that.
Right. Right. Yeah. And that's, and the world's starting to open back up, thankfully. So that's, a temporary issue, but, yeah. And so so you are you, I mean, you obviously are liking academics because you're staying in it. And what would you, because I think you give a little brief like overview of what your service percentages are, but like, for instance, when you're in, so you're mostly service diagnostics. So what
Mhm.
are you doing during that time? I know, but,
Yeah,
and
yeah,
especially as a
definitely.
lab
And I
director.
think that's also, oh, and I think that's a great segue for like, also like, do you need to have a PhD? Do you need to have a master's, right? So I
Hmm.
think, and this kind of like goes back to your interest in training. I 100% agree with you that you need to ask the program, and the program should be telling you what your day looks like and how structured. And
Hmm.
we are 100% up with our applicants and tell them like, look, like we're not super structured. It's not like we're unstructured, right? We're kind of in the middle. But if you need someone to, if you need exams every month, and you need, specific book chapters and all of that to succeed, we're not the program for you. If
Hmm.
you like to schedule your own time, except when we tell you you need to be somewhere, then that's us, right? So I think that was a super great point that you brought up, that honesty is
Yeah.
really important both ways. Um,
Hmm.
and then, yeah, whether or not you want to do a PhD or you want to do a combined program, Minnesota was not a combined program. I knew that I didn't want to do a PhD. I enjoy my collaborative research, but I didn't want to do a major research program. But I think what's important, yes, is to recognize that now in academia specifically, there's a lot of different avenues. You don't have to be a PhD, right? So I'm technically like a clinical track faculty member, right? So like I do some research, but I'm not expected to pull in like big grants, or anything like that. So I don't need to have graduate training. Granted, I'm not tenure track eligible, but that varies by institution whether or not you need a PhD to be tenure eligible. I know plenty of people who don't have graduate training who still do a lot of research and are tenure track. So it really depends where you work. But yeah, so my day is, so clinical service is resident training, a lot of resident training, right? So our residents are sometimes in the room by themselves, but a lot of times, even if I'm in a meeting, like I'm on the other side of the room, in a meeting on Zoom or something. So it's a lot of resident training, going through cases together, kind of daily cytology submissions, hematology reviews for pathologists review cases, and then a lot of like result validation. So the technicians, our medical technologists will pop their head in and be like, hey, does this result make sense? Or, the analyzer's kind of acting up, like, do you have any troubleshooting guidelines? And then we are what I love about Minnesota, and not to like harp like, oh, Minnesota's the best. Just what I love about our hospital is the ClinPath lab is set in the middle of the hospital. So we are not like a lab that is like in another building or on another floor. Like we joke that like
You're not in the basement.
exactly, all hallways lead to ClinPath, which is true. So
Wow.
we have a very, very, very clinically interactive service. Clinicians,
Nice.
resident interns, students are constantly coming in and out of the room. Granted, it actually, some days it's hard to get work done. But
Yeah, that's how ours was too. And I loved that collaboration, except if it was like 5 on a Friday and I had like 2
yes,
more bone marrows to do. And I'm like, all right, everybody get out. But when you
yes,
know people, you can be that kind of open and like be gone, everybody, and nobody's getting upset. So
exactly. Yeah, so that's like most of the clinical day, which, it's like recommending additional diagnostics and, consults on how clinicians should work up the case. It's a very interactive, and I do feel that like I pull on my general practice experience, which for that, it can be biasing 100%, right? But I pull on that, but it's not a necessity to have, it is not a necessity to have been in practice to be a good pathologist. I don't want to make that's the assumption, because that I work with plenty of pathologists who did not practice who are wonderful pathologists. I think it just gives you a different perspective on, your recommendations and where you're coming from.
Mhm. Yeah, and even, I mean, even if you didn't practice, just I think there is value in staying up to date with the clinical literature as much as we can. There's only so much we can do, and we're certainly not, making treatment recommendations for the most part. I mean, we're qualified to, we're veterinarians. So if you feel comfortable with that, then more power to you. But a lot of pathologists are not comfortable necessarily. I know I'm painting a broad stroke, but in general, we stop at diagnostics, but there is, I mean, that's what I love about clinical pathology. And one thing that, is the theme and the things that you're saying is that being collaborative and working with the clinicians and knowing, using the pieces of the puzzle that they're, collecting, including history, signalement, other tests they're doing, and using that in our interpretation to help solve the puzzle. So, I mean, it's not, it's not necessarily, I mean, bias is not always a bad thing when it helps you get to the get to the answer, you know, and whether that's your own experience in practice or just you've read, you know, the literature, you're keeping, you know, up to date on your CE and in other areas of medicine that are not necessarily clinical pathology, or, you know, taking in any information that isn't necessarily just pathology. Like it can help you be a better clinical pathologist. So, and so, and that's one thing that too comes up is, you know, since you have that clinical experience, which I think is awesome, because a lot of people, you know, you hear this too, a lot of people that are in practice say, well, I've always had a, you know, interest in clinical pathology. I'm kind of thinking about going back and doing a residency. And so you feel, and I know it's a, you know, just like you said, it doesn't mean you have to have been a clinician to be a good clinical pathologist, but do you feel like that did help you? I mean, that's kind of where you were going with that, is being able to sort of speak that language or draw on your experiences in practice, and
Yeah,
how do you
yeah.
use that in your job now?
Yeah, I think it's just a different skill set, right? Like we all have different skill sets. So I can say, you know, like one of my coworkers has a PhD, you know, is a big researcher, right? And he brings a very, I think, interesting and different skill set when he's on clinics. And he pulls from that heavy research background. And he really can like look at things from a different perspective that I don't always look from. So, and I have another coworker who was a certified veterinary technician before she went to veterinary school. Now she never did clinical practice, but she was a vet tech, you know, before that. So she's able to draw on that clinical experience for her background. So I think we all bring positives and different perspectives. And so it's interesting, like when we all come together on a case and we all bring our different experiences. I think for me, like it's just like, oh, I've seen this before, I've treated this, you know, or like I know
Mm-hmm.
how this goes, or like I kind of have an idea about like the financial limitations of this. It's very easy to sit, I joke, like we sit in our ergonomic chairs all day, right? And it's very easy to judge what clinicians are doing, because we have none of that client stress at all. And we have none of that financial stress or any of that. And so it's very easy to kind of sit there and judge and be like, well, I don't, and I'm not saying that I don't judge, because I do as well. Like I am not perfect.
Natural, everybody
Um,
does.
yeah, but I think it allows you to have that perspective of be like, okay, well, maybe that's why this was managed this way. You know, here's the reality of the situation. It wasn't perfect, but this is how it had to go. So I think it brings that background. But
Humility.
yeah,
Yeah.
but it's
Yeah.
not a
And
necessity.
I
You
get
know?
that.
Yeah.
Yeah. Yeah. You don't have to have had the experience to be sympathetic, but it's nice to have had the experience so you can be empathetic. So
Yeah.
you've been there. And I mean, I only did an internship. I didn't do actual general practice, but I'm married to a general practitioner slash ER veterinarian. So I have that kind of, you know, secondhand ability to see into the world that they deal with, and their limitations that then affect us because we have to work with what they're able to work with. So just understanding that is awesome. I think that's a huge part of it. So I'm glad you brought that up. And so you guys, you had mentioned, so you, okay, this is switching gears a little bit.
That's
I'm
fine.
just
We're jumping all
curious
over
because
the
I,
place. We're jumping
well,
all
that's
over.
okay. No, I love it. That's like, seriously, all of this is great. So, because I did that survey, and a lot of these things are things that people have asked or said, like, I wish I could ask these things to a pathologist. So this is awesome. What are you, and I'm curious about this because we haven't really talked about this since, you know, anytime really, but what are your like actual uh interest in our specialty, like your focus is? And I know you don't do a lot of research, but like what areas as far as diagnostics or research that you are doing, you know, are your areas of interest focus?
Yeah, so I would say most of my research ends up being like collaborative, right? But I do have an interest in kind of like improving diagnostics. So, you know, whether that's evaluating diagnostic rating schemes, we're doing a excuse me, a project right now with a resident where we're kind of looking at cytologic rating of cutaneous mast cell tumors and kind of
Well, that's a good
tumor
one.
heterogeneity and stuff. I do find like the day-to-day diagnostic relevancy really interesting. I have started to gain, and this has been kind of part of the lab director role, but I teach clinical chemistry here. That's the course, one of the courses that I teach in. So I have learned a lot about like interferences with kind of analyte testing, and I've now gotten a few cases out there with working with some residents or some soon to come out cases. And so I do find that really interesting. So I'm always kind of keeping my eye out for like interferences that maybe we talk about but haven't been published on or haven't been evaluated. So I find that kind of interesting. So I would say those are probably my two main areas of interest. But like my resident research was on cell block, which is for those of you that haven't heard of cell block method. So it's when you take a cytology sample, you concentrate it, embed it in paraffin, and then you essentially then treat it as a histopath sample. So it kind of bridges both gaps. And so I looked at like characterizing lymph node enlargement and lymphoma with that. So, but again, that's still kind of teetering on the diagnostic side. So I'd say a lot of that kind of applied clinical research is where most of my interest is.
And didn't you say you don't like statistics? That sounds so statistical.
Yeah, so I am not a huge statistics person. I am very lucky. So I guess to touch on what a lab director does.
Yeah, I would like to know, because
it varies across.
I'm not an academic.
Yeah, it varies across where you're employed, and I can't speak to like what a lab director does like at a private diagnostic lab, but on the academic side, it's quite variable, right? So some institutions, their clinical pathologist lab director has like a 90% lab director appointment. I'm 10% or so lab director appointment. And the reason being is I have a wonderful lab manager and a wonderful lab supervisor. They're both medical technologists who do a wonderful job of running the lab, day to day. We have most of our staff are medical technologists. They are all very good at QC and QA and all of that stuff that comes as part of their training. So I'm very spoiled that they do that. But a lot of what I do on a kind of day-to-day lab director basis is, SOP, so standard operating protocols, procedures. If we bring a new analyzer in, I work with my lab director and supervisor on validation, quality assurance, quality control. It's a lot of PR work. I joke that 90% of what I do is PR. So I'm just dealing with angry clinicians or happy clinicians or angry clients or happy clients, right? And just kind of solving problems. And we have a lot of external researchers who submit samples to us. So I end up doing a lot of, they'll be saying, okay, we're doing a liver toxicity study and we want to do it in these rats, and I'll be like, okay, well, it would make sense to run these chemistry parameters, and because you have a limited sample, let's not worry about these ones because they have nothing to do with the liver, things like that. So consultation, data evaluation is a big part of the job as well. And I think that, again, the hands-on portion is just dependent on what your appointment is. So some people, because my lab technologists are able to do a lot of the stats work, I'm more peripherally involved. I learn more from my medical technologists, I think, than they learn from me. Definitely, I learn way more from them. But I think some lab directors who this is mostly all their job, they're more heavily vested in that.
And I love it too, because it's one thing I think comes with time and just maturity in the job that you're in, no matter what that is. It's just learning that you don't have to know or like everything, and it's okay to get somebody else involved and say, I don't like this, or I'm not good at this, or I don't have interest in getting better at this. So let's, obviously you can't do that if that's your job, like if that's what you were hired to do. Like, I don't want to do this thing. If you are a statistician, you can't dislike stats. But if I'm the same way, I'm not a numbers person. I don't, but the peripherals around it are very interesting, diagnostic, testing and stuff. But yeah, I mean, that's what other people have jobs for, so they can help you and especially with your lab staff, knowing how their strengths and utilizing them. I mean, I learned so much from our lab technologists when I was a resident. I mean, I didn't know what I was doing with half the stuff, and they taught me everything. So just being able to say, like, there are people that are better at this than me, and I have something to learn from them, and that's all of us all the time. There's always somebody that.
Oh, exactly. And that's when I took this position, I was hesitant because I was like, look, like, I don't know what I'm doing. Like, we train our residents, a little bit about what lab management looks like, but I'm like, I've never managed a lab. Like, I don't know what I'm doing. And my mentor, she's like, listen, I stepped in the same way. She's like, you don't know how to do this until you do it. So she's like,
it's just like incoming residents.
Exactly. She's like, just listen to what they're telling you, do what they say, because they're not, the 99% of the time they're right, and you'll learn as you go. And that's really what it's been, is me just, I mess up sometimes, and sometimes I do things right, and every time is a learning opportunity. And yeah, like, I don't love stats, but I have to do it as part of my job, so I'm slowly learning as I go, right? And that's just the best you can ask and hope to do. So.
Yeah, that applies to so many, to all of our positions. I think we all just sort of in vet med think like you're all alone and you're supposed to figure all this out on your own. That's just not the case. But all right, so what is, again, this is switching gears, but I put this in the sample questions. So what is one of your favorite cases you ever diagnosed? I know that's a loaded question because there's a lot of them, but like, what's just a cool case that you've had, whether it be like just based on the, it doesn't have to be cytology, but based on the cytology, or even because the whole case was cool because of collaborative effort or whatever. If you have something in mind.
Yeah, so I have like one and then like a half. So my favorite is truly, it's not a cyto case, it's actually a clinical chemistry case. But
Nice.
I will say, like, I had, I don't know if it was like last year, it was at the right before the pandemic, I had like a toxo, neospora, and sarcocystis case in like a 3-week period. And I was like, what is going on? You know, like found like, we found like neospora in peripheral blood, we found sarcocystis in peripheral blood, and then we found toxo in like a BAL sample. And up until then, I had never seen it like outside of glass slides. And I was like, what is going on? Like 3 cases in, you know, like 2 weeks. So that's probably been like the most fun cytology. But my favorite case, and I think it just goes to show kind of, again, like being a pathologist, is a clinical pathologist, is not just about cytology or slide review. We had an intern who was working up a case. This was actually back when I was a resident. We had an intern who was working up a case. It was a dog, it was a down dog. And so they were assuming it, you know, was like a disc or something along those lines. And so he came in and he's like, hey, can you look at this blood work? Like, it's just a little bit unusual. And so the dog had some so his ALT, AST were high, so some hepatocellular damage. And then the CK, which is a muscle damage enzyme, was super, super high, like really high. And they're like, we're just thinking this is probably just due to, you know, the dog being recumbent. And I was like, this is not a cow. It's not a horse. Like, this is way too high for recumbents. Like, it just doesn't. And I was like, look, like, I think with the hepatocellular damage elevations and the muscle damage, like, you should be looking for like sarcocystis in this dog or something like that. And they kind of poo-pooed it, but I was like, really, like, this is not fitting a typical like just down dog. So they took the dog, did an ultrasound, they did cytology, which of the liver, and it was just mixed inflammation. We couldn't find any organisms, but it was very inflamed, which was unusual. So we recommended, you know, biopsy for evaluation. And luckily, what was funny, what happened is while they were doing the true cut biopsy, they accidentally got a small sliver of intercostal muscle. So on biopsy, the liver came back as just pyogranulomatous inflammation with no organisms, but there was a single cyst in that muscle sliver. And so then, and it was sarcocystis with additional testing. So that was, I'm like, oh, look at the power of clinical chemistry. You know, like,
did you just walk out there like,
I know, I was like, I'm the smartest person ever, but I do think it's fun. Yeah, and I think that's what's fun about heme too, right? Like, we can sometimes look at a case and be like, well, I bet this is the diagnosis, and you don't even have the answer, right? Not that we can always do that, but that I think was just fun because it was, you know, like, I could have been totally wrong, but I just happened to be right.
Right. Well, but no, you don't give yourself enough credit. But yeah, I mean, that's one thing that I've learned to really love about clinical pathology too, is just how you can change the clinical course for an animal just by sometimes just a simple test. Like you said, heme. I mean, I think the blood smear is not given anywhere near enough credit as it should be for workups. And, you know, just this isn't anywhere near as exciting as your case, but, you know, we had an anemic dog come into our specialty hospital and get admitted for IMHA. And they ended up submitting. So it was referred for IMHA. It was admitted as an IMHA case, but they did do a blood smear review to me. And I was like, well, this dog's microcytic, hypochromic, and, you know, explained that pattern really suggests strongly iron deficiency anemia from chronic external blood loss. So we went through all those, you know, is there any of this? Is there any of that? You know, does it have fleas? Does it have hookworms? Blah, blah, blah. No. But they did notice that it had melena, and that could be the source. That suggests the source, and they ended up going doing more testing. They did abdominal ultrasound. I think they probably did a CT too, but in the end, they ended up taking the dog to surgery because it had a stomach mass, a bleeding stomach mass, and it was ended up euthanized on the table, which was a sad ending. But this dog didn't just sit getting treated for something it didn't have for, and spending, money that didn't need to be spent. And not that there was any, nobody did anything wrong there. They did the right thing. They had the smear evaluated to give clues, and just that one clue was like made a huge difference for the whole case. And that's the power of clinical pathology and involving the clinical pathologist. And just like your case, which awesome. Oh my God, really? A sliver of intercostal muscle? Like, wow, what
I mean, it was
an
super
awesome
lucky.
case.
It was very lucky.
Well, I mean, sometimes luck's all you need. You just get a little luck on your side, but that's really cool. Well, I love it. And I mean, so I guess just wrapping up, because I could talk forever. And this has been super helpful, but would there be anything that you would, I mean, we've talked a lot about like suggestions for people that are interested in ClinPath, thinking about going into ClinPath residencies. Is there anything else that you would suggest to people about going into this, and not necessarily just what there is on their application, or if there's anything left there, but just what you love about this career, and like what I think, or what you might think that people need to I don't know, just think about when they're considering it.
Yeah,
And we've kind of touched on that, but if there's
yeah,
anything else
no, and I think there was one other thing I wanted to bring up, because we get this a
yeah,
lot
anything.
from students with regards to like when they're looking at residency, is how important is doing an internship or clinical practice before you go into your residency. And I'll honestly say it's very dependent on the program. I would say a lot of the programs that are not combined with graduate training are trending towards preferring candidates who have some kind of clinical practice, whether it's an internship or not, whether it's a specialty ClinPath internship or not. But that is by no means the rule. And we will still look at applicants, who are coming straight out of school. And so I think programs that tend to do more combined graduate training, I think they focus less on the clinical experience, because again, like if you're doing a program that's combined graduate training, then you probably have a significant interest in research. And you don't necessarily need a lot of, to be a great researcher, you don't have to have a lot of clinical experience, right? So I think there's some variability, but I have noticed a trend amongst institutions for especially the non-graduate ones, because those are the ones I guess we compete with, right? Because we're dealing with the same applicant pool, that there's a lot of, we like to see that clinical experience. But again, it is not a necessity, and we definitely have had very strong candidates who did not, who came straight out of vet school. Yeah, I guess I would just hark back to just, like making sure that, this is really what you're passionate about. I think that's really important about any residency, is just really, like, you can burn out during residency. I see it happen, not really with our ClinPath residents. I think we try and do a good job of making sure that they have some quality of life, but some of those specialties, it's draining. And so I think, you need to make sure you're really committed. If you've been out for a while, just recognizing that you're going to have to start studying again, which getting back into that frame of mind can be really difficult. And
Studying a lot, especially, and I
yeah.
can't speak for other specialties, but ours is so cerebral, and there's a lot of reading. I mean, we read a lot of books multiple times for our board study, 5 years of journals going back for multiple journals. And yeah, it's a lot of studying. Some people get really jazzed up. Like if you find yourself hearing this and thinking, oh, I think, you're kind of like it's a challenge, but you're like, oh, I kind of can see myself doing that. Like you're excited about it, then that might be an internal clue. Like this could be, keep going. But if you're like, I'm so done with studying, then
yeah.
And
I don't want to make this sound like, I don't want this to sound negative. Like that is not the intent. Like I love my job. I'm really happy I did residency. Like clinical pathology is just really exciting to me. And every day is like, I just feel like, every day is kind of an adventure, and every day it's like, every day is a mystery and you're trying to solve the mystery. And that's what I really like about it. But I just, I think there are some realities that I didn't know. And now that I think the other thing is, again, like if you may have this perception that being a pathologist is easier than being a practitioner, again, I just want to make sure you understand that there's just different stresses.
It's different.
It's tiring staring at the microscope all day and really having, you're really having to hyper focus the entire day because you don't want to miss that one organism or that one med. So again, it's just a different type of stress. And so you just need to be aware that, you know, you're not going to solve all of general practice's problems by going into ClinPath, but anybody who's interested in it, like I think I wouldn't be doing it. Like, I don't want to do anything else with the rest of my life. You know, my significant other hates how much I love this job, you know, because it's all I want to talk about, and I don't, you know, mind working after work. And, you know, I love going to work every day, and as much as you can love going to work every day. But I just, like that mystery of figuring out what's going on and trying to be helpful.
Yeah, that's the theme, I think, in ClinPath, is just the mystery and the, do you remember the show Mystery Diagnosis? We're the same, we're roughly the same age. So it's not that it was on TLC, I think. You should look it up on YouTube.
I think I vaguely remember it, yeah.
They have some new kind of version of it on, I think, Netflix. It's called Diagnosis, but it's a little I don't know, it's a little hokey. Although Mystery Diagnosis was really hokey. It was a human medical show, but it was, you know, they built it up like, oh, there's this mystery illness this person has, and then they solve it. And it's like, and I just loved that show. And yeah, not every case is going to be like this big mystery. I mean, we've got plenty of non-diagnostic samples, plenty of cell tumors, but, you know, even those are fun sometimes, you know, because the easy ones you can flip through. But yeah, it's the mystery of it that's really cool. And I share that same like the thing that gets me fired up about it. And but yeah, no, it definitely doesn't sound negative. I think it's good for people to understand what it is. And that's why I'm doing these chats with people, because I just think we live a little bit in a black box of what exactly we do. And there's not a ton of information in school, at least what I'm understanding, for people to get exposure to clinical pathologists on a day-to-day basis kind of thing. So I think it's great. I mean, all this is super good information, because if you're hearing this and you're hearing, like, I think it's just good to say, like, even though studying, when we say, oh, there's a lot of studying, that's exciting for some people. I mean, some people really like to study. I like to study.
And I mean, you can write, if you can get through the 3 years, right? That's all you got. Like, and I think ClinPath is definitely, like all practice, it's a continual learning, right? I think
exactly.
The hard part of any I mean, it's really not any different from general practice, but like when you're a specialist, the expectation is that you're on top and up to date with all of the literature, right? And there's a lot of it, right? And so you're constantly learning. For me, training residents, right, we're forced to keep up because the residents have to keep up. So I don't know.
You don't want them to lap you.
I wouldn't keep up this well probably if I was, you know, not training residents. But you know, it's a lifelong commitment to learning and to staying better. And yeah, there's nothing more exciting than like having this nebulous fever of unknown origin animal, and you're like, I found the blasto, you know, the one blasto. Like, yes. So there's just something, like it's helping the animal, it's helping the owner, you know, it's helping the vet. You know, you feel really like proud of yourself.
Yeah, I feel you on that. That's one reason I love infectious disease, because once you find it, it's not always that easy. Sometimes you're like, okay, this could be these 3 things, but at least it tells you, like, this is an infectious process kind of situation. So yeah, I love it. Well, this has been so good. I love everything you said, because these are all the questions that people have asked me, and I know that you get asked all the time, and you have such a unique perspective being in academics, and especially, you know, being on the residency board and being a lab director. Like, that's all. It's cool to talk to people in different areas, because again, there's so many things you can do. It's just like you said, it's not all just cytology, it's not all just diagnostics, it's not all teaching. There's so many different areas that people just don't even know exist. So thank you for coming and showing, you know, everybody what you do and telling everybody about all your perspective. And unless there's anything else, I'm gonna hop off the recording and you stay put, because I want to say hi off the recording.
Definitely.
But thank you. And if anybody has any questions for Dr. Heinrich, then I'm not exactly sure where to put them, but I'll let you know.
Yeah, well, you can, I mean, obviously I pay attention to the cytology Facebook thing because I'm always commenting, but my email is pretty easy to find at the University of Minnesota, you know, vet school website as well.
Yeah,
so.
if you're cool with people doing that, you know, and emailing you with questions if there's people that have, you know, don't spam them with stuff, but if there's people that have, you know, questions for Danny about any things we talked about, then thank you
Yeah.
for offering.
I may not answer right away, but I will eventually get there. So
Yeah, no, that's okay. I think that's all of us. Email is my email's back way up. So, all right. Well, thanks, Danny.
yeah,
Thanks again.
thanks.